Welcome to Akoma Conversations, presented on Akoma News Network, with your hostess, Dr. Bertha Serwa Ayi, a medical doctor, specialist, author, and speaker.
Well, thank you for joining me today. My name is Dr. Bertha Serwa Ayi. I'm the curator of Akoma Conversations, and this is a platform where we talk to thought leaders, people who are making a difference, and try to learn from them, as well as have an opportunity for them to inspire the next generation. And today I'm in Addis Ababa, Ethiopia, at a conference called the Consortium of Medical Schools in Africa. Today is day 2 of the conference, and one of the panelists who spoke today is my guest, Professor Ahmed Rhassane El Adib from Morocco. And he's dean of a medical school over there and also oversees the technology strategy for about 6 other medical schools. So I'm going to let him introduce himself, and then we'll ask him a few questions about his presentation, because today he talked about using digital assessment for medical students and moving away from the paper evaluation and assessment. So I'll let him introduce himself. The caveat is his primary language is Arabic. Yeah. He went to school and studied French and learned medicine in French. And so he says, as a disclaimer, he has to think in French and respond in English. So you'd have to bear with him. So thank you for joining me today.
Thank you, it's a pleasure.
Yeah.
Thank you for this kind presentation.
Right. So you did a wonderful presentation. Tell me a little bit about yourself.
I have many hats.
You have many hats?
Yes, many hats. I'm professor of anesthesiology, critical care, and emergency medicine. And I'm head of the department of anesthesia and critical care specific to gynecology and obstetrics in a huge maternity.
Critical care for specifically obstetrics?
Specific gynecology and obstetrics. We have a maternity of 18,000 delivery per year.
18,000?
Yeah, African context.
Yes.
Yes. And we have a service in critical care specific to that, with a huge number of admissions for preeclampsia, postpartum hemorrhage, and disease related to pregnancy. And that's what pushed me to simulation and to pedagogy.
Pedagogy. Okay.
So I'm the dean of Mohammed VI Faculty of Medicine in Marrakesh, and I used to be the dean of Mohammed VI Faculty of Medicine in Casablanca for 2 years. I'm also, because I started many projects in Casablanca, I'm the executive director of AI Health and Pedagogy Chair for the whole university.
Wow.
Our university, Mohammed VI University of Sciences and Health, is an ecosystem including university hospitals, laboratories, research centers, and for studies it includes all the students related to health, even doctors, dentists, pharmacists, engineers in health professions, nurses, all health professionals, others like orthophonists, kinesiotherapists, and also, so it's an ecosystem with many studies in different healthcare professionals and around healthcare in 5 cities.
5 cities.
Yes, 5
Casablanca.
cities. Casablanca was the first one in 2014, and after Rabat, after Dakhla in the Sahara, and last year Marrakesh and Casablanca. I'm from Marrakesh, so when Marrakesh opened, I moved to Marrakesh.
Marrakesh, so that you can actually live there.
Yes, sure, in my home country, in my home city. So it's a pleasure to build something there. But in Marrakesh, I'm not only the dean of the faculty, I'm also the general director of the campus with different specialties, the university hospital and the project ongoing.
Wait, so how are you able to do all this? I mean, there'll be medical students and doctors watching. You're doing anesthesia, emergency medicine, critical care. You're overseeing AI and technology for all the five.
There are some other hats. I'm also president of Moroccan Society of Emergency Medicine. I used to be the president of the Moroccan Society of Anesthesiology and Critical Care. I'm involved in many international institutions. Patient. I'm passionate about what.
You're passionate about. So you wear a lot of hats. I mean, this was going to be about your presentation, but it's almost veering into leadership. How are you able to do all these things? Is it because you wake up early? Is it because you have a lot of assistants? Or maybe you're just super smart and a little bit above?
No, it's when you have to train, you have to have.
You've built a certain skill set.
Yes, own skills. And with developing, you build team around you. I have a magnificent team magnificent team in my service, my clinical service. I have magnificent team in my school, medical school. I have magnificent team in university and in the society. And this.
Okay.
So with these teams, we try to work together. We exchange, but. Also with that, I write articles, I read, it needs some organization and prioritization. Also,
okay.
It's important to prioritize in every moment what is most valuable and can give results also.
So, I mean, for those of you watching, Professor El Adib is a prototype of what a good leader should be. Like if you ever take a course in leadership, they're going to tell you how to multitask, how to respond to your emails, be a little bit of everything, and be able to use the people around you to prop you up. Because
I studied for that.
You studied. Yeah, you did a course in leadership.
Yes, last year I had a certificate for management and leadership.
Management.
And this year I'm studying an MBA for management for health management. I'm still a student.
You're still a student. Yeah. So I did an MBA. So you and I are compatriots, but you finished medical school in 2000.
Yes.
I finished in 96. But I also did an MBA with a focus on health services administration. So I had to take a course on leadership, which is why the first case study they give you is exactly what you're describing. Somebody who comes to work and they've got a ton of emails, they have many responsibilities, but you're still expected to be efficient. And you seem to be a prototype of that. You're managing critical care, AI, innovation, president of emergency medical, whatever, and then you're doing MBA and you're still studying and still reading and writing articles. So I want you to, for those young doctors watching, you can be like him. It is very, very possible, right? So tell us about yourself.
I hope to be a model.
What?
I hope to be a model, but...
and then do you have a wife and
have to be. Yes.
You have a wife and children too?
Yes, I have.
How many wives?
My wife is also a professor of medicine.
Your wife is a professor of medicine?
She is the head of the department of endocrinology.
Endocrinology.
And she is the director of the Center of Pedagogy in Marrakesh Medical School, the public medical school. And we talk pedagogy at home.
And pedagogy, to explain to the audience, pedagogy is the art and science of how to study, what to study, learn, the methods of delivery, yes, how to train. So it's all the ecosystem about studying.
Yes, exactly.
Is that how the two of you met? You were meeting around pedagogy, or you met in medical school?
We met in residency.
Residency?
In residency.
In
Casablanca.
In Casablanca.
In Casablanca. I was in internship in Casablanca. And we met there, and it was...
the rest is history.
The rest. And now we have 3 children, 2 daughters and a young boy.
Okay, and how old are your children?
The oldest is 19 years old. She's doing business school. And the others are in college, 17 and 16 years old.
Okay, wow, outstanding. So let's talk about you. So are you, in the midst of all this, does your wife think you're a good husband? Or do you feel to your children you're a present father? Or you feel your work takes you away so much that you can't be at home? Like, in other words, can you have it all, be all this and still be a...
I moved, I'm not present. I moved to, when I was dean in Casablanca, I moved alone to Casablanca for 2 years. And they stayed in Marrakesh. It was difficult for all of us. So I came back to Marrakesh and I had the opportunity to have this new medical school in Marrakesh to join my family. But it's an experience I lived myself. When I was young, my father was politician, my mother was professor, they was moving and
Professor,
traveling.
you said professor, was it history or?
University, letters, letter and yes.
PhD professor.
Yes, and they were politicians, they were traveling all the time, and I felt with lack of parents, but when and they were militant.
Your parents were militant?
Yeah, militant.
Even though they were academicians?
Yes, and now what I'm doing is militantism. It's pedagogical
Militantism.
militantism. I want humanity. I want Africa to be much better, to improve. I want to share knowledge. I want to share competencies. So that's my militantism. So when I grew up, for me, I told they were doing something good. So if we show our children a model of integrity, of generosity, they can forgive us.
They can forgive us. Yeah. Oh, you mean your children?
Yes,
they can forgive us by looking at
what. They will forgive
one day they'll look at your work with pride and say, you know, maybe the cost of you not being present so much was worth it in the broad context of African improvements, right? So you were born in Morocco.
Yes, in Marrakesh.
Marrakesh. You grew up there, and you did your primary education.
Yeah.
But you said you went to medical school in Tunisia.
In Tunisia, yes.
Was it hard? Why did you do medical school in Tunisia instead of Morocco? And how difficult was it to get into medical school?
I had the score to attend medical school in Morocco, but in this time it was administrative problem that I didn't have the chance to pass the entrance exam.
For Morocco?
We had only two
medical schools at that time.
At that time, and I sent the letter. We didn't have digital system. I sent the letter in the deadline.
After the deadline.
So I couldn't pass the exam entrance. So I wanted to be a doctor. So I sent letters to at least 6 or 7 universities all over the world. So I had acceptance in Oxford, in Houston, in Belgium for doing medicine, and in Tunisia. So my parents told me it's the same country, it's a country like us, the same culture, the same language, and they convinced me to go to Tunisia, and it was a very, very good choice.
Good. So Tunisia is, let's see, Tunisia is sort of...
in the north of Africa.
It's right next, so this is Morocco and...
Between Tunisia and Morocco, there's Algeria.
Algeria. Yeah. So then you could go back and forth home?
It's 2 hours.
2 hours. Okay, Tunisia is right there. Okay. Yeah. So you
2 hours by plane.
Oh, by plane? One flight?
Yes.
I see. So your parents did not want you to go to Oxford, Belgium?
That's the issue.
Was it cost? Was it expensive or?
No. I had a scholarship for Houston.
Houston.
I had a scholarship for that, and the
in
choice
Texas,
was in
United
Texas.
States.
Yeah, and the cost was accessible, but the choice it was to train in the same cultural environment. Because many of us, if they want to do this profession, and anywhere, everywhere, it doesn't matter. But for me, it was sure that I will be a doctor in Morocco and serve my citizens.
Wow.
And for me, it's better to train in the same cultural, professional output.
Outputs. So this is very, very remarkable. For those of you watching, if you're a student, this man had the opportunity to go study medicine in Oxford, United Kingdom, Houston, Texas, but he chose to study close to home because he felt that he wanted to be involved in his culture and be able to practice medicine to his people and just be culturally very relevant, right?
Yeah.
So this is similar to what we are doing with consortium of medical schools in Africa, that people would stay home, study the people, and be culturally relevant. So, I mean, I think that's a very important decision.
Because you could have gone to America. To go for 1 year, for 2 years, to have other experience, to see other systems, to discover other cultures, and to gain competencies that we don't have in our countries. Going forever, for me, it was not an option.
It wasn't an option.
I dreamed to be a doctor since I was young. I want to be doctor in Marrakesh, in Morocco, serving my population. So
that was. So this is interesting. You tried Morocco and you couldn't get in, and you tried Tunisia, and then suddenly you have offers from all over the world. How did that make you feel? Do you understand? You want to go to Morocco, it's like no chance, and you said, I still want to be a doctor.
Yeah.
I'm going to send letters all over the world.
If you have the dream, we have to...
So in other words, you have a dream, pursue it. If one door closes, many other...
It can't be realized 100%, but we have to give ourselves the tools to do it. So if I want something, I give myself the tools to realize it.
Wow. So, because you're really inspiring me right now. So you finished medical school in 2000 in Tunisia, and then you go and subspecialize in anesthesiology. But then you also mentioned you're a chair of emergency medicine critical care. Can you explain when you studied all these?
Because in Morocco, in the system, we didn't have emergency medicine specialty at that time.
Okay.
And we had, and in Morocco, the specialty for anesthesiology and critical care are the same. In the Anglophone system, you have anesthesiology alone and intensive care alone. In Morocco, we have the same.
Oh, it's combined.
So for sure, when you involved in specialty and you finish, you have this specialty. And when you start teaching, we teach anesthesiology, critical care, and also emergency medicine. And through my experience, when I was resident, I built many projects. I did the project for building the new emergency department in Marrakesh.
You built it from the scratch?
No, I proposed the architecture build, but I proposed a new architecture of our emergency department, and I worked in emergency department for a long time. I worked also with my colleagues to build the pre-hospital system and the regulation center. So I worked in emergency medicine. And after I did pediatrics, and after I did gynecology and obstetrics. And obstetrics, by definition, it's an emergency situation.
So you finished anesthesia and critical, and then you went to study obstetrics and...
anesthesiology in obstetrics. It's subspecialty.
In obstetrics and gynecology,
yes.
okay.
It's
so that's where you talked about the 18,000.
Sure, when I developed research and credibility in that part, and I became in 2015 the president of Moroccan Society of Anesthesia and Critical Care. I did 2 mandates. And after my colleagues, because emergency medicine became to start a specialty, official specialty, they were young, they wanted a lead, and I had the experience to lead this young society and this young specialty to become recognizable, to develop colleagues and to develop emergency medicine in Morocco.
Wow.
It's a young specialty.
Wow. So I'm blown away by how many credentials you have. And I'm going to ask you about the topic you presented today. But I want to know how you got into medical education, because I have, I'm going to be setting up a medical school system called Akoma. Akoma stands for the Heart, Akoma Global Academy, to train doctors. And I'm also building a Pan-African network of healthcare providers, starting from medical students to faculty, so that everybody can talk to each other, so that a medical student in Zambia can reach out to you about a project. And it's called Akoma Health Sciences Society. So it's just a society with members. So that's how come I got interested in your project. So tell us how you got into medical education and pedagogy, and then the project you talked about today with the Moroccan system. So you can
it's a long story. Pedagogy, it's with mentors. I had a fail in my life in the fourth.
You said you failed your fourth year of medical school.
Yes, but it was a jump for my life, because I did some voluntary internship. I discovered many things, and this year I discovered that simulation is very important for training. I discovered that I did an internship in legal medicine, so while doing autopsies, I discovered that there are many errors in emergency department, in critical care, in diagnosis.
Oh, because you did the pathology,
Yeah.
the people were dead, but you could see the errors that they had made.
Yeah, sure.
That was, I now understand.
The professor, the head of this department,
of the pathology,
he told me he was doing
autopsies?
No, he was doing internship in pedagogy. He became a dean after. So he was interested in teaching, and he told me, you have to do this specialty of pathology. And I told him, no. In medicine there are many errors, and people need to train. And my specialty in future will be a specialty just before that. So emergency medicine or critical care. So I did that, and since the beginning of this specialty, because anesthesiology is like a flight, where you do induction, it's like the flight going on, and the same mechanism of accidents and errors. So I was
happen. You mean after you induce a patient?
Yes.
They're on a plane.
On the plane,
to
it's
get
the
to a
same
destination.
like aviation, and simulation is developed in the aviation. I was convinced that simulation is a tool for training, very powerful. And I did many trainings with American Heart Association and an instructor course in Philippines. And when I became and I decided to be a professor, and I passed the exam to be professor. And when I became professor, 6 months after, I put a project in my faculty of medicine about a project for simulation center.
Simulation center?
Yes. So the project were going, we had problems to finance and to have mannequins, so I suggested to the dean this time to train professors about pedagogy and simulation training. So we did that, and when we finished, we decided to do a low-cost center of simulation without mannequins, just role plays, and we developed that, and we institutionalized simulation through the curriculum. So all the students in Marrakesh Medical School did simulation, and through this, the simulation center grew.
It began to expand.
Expanded, and I had responsibilities, education manager, and after I became the coordinator of the pedagogy committee of my faculty, and I went to university commission and dean in Casablanca.
And so this is something you didn't plan?
No.
You wrote the exam to be professor, But the simulation just started a whole new...
Exactly.
Wow.
Exactly.
So how did you go into digital? What made you move into digital assessments after getting into medical education?
The most important thing is the challenge of massification.
Massification. So explain that to me. I've not heard.
Massification. Now we have lack of doctors in Morocco, so we are doing entrance of hundreds of doctors at the same time.
And it's called massification.
Yes.
MASSIVEVI. Massification. FIC.
So,
wow, I've never heard that word.
A big number of students.
You know, that excites me. You know why it does? You know, many years ago in Ghana, there was a plan to build a center, a medical education facility that will produce 3,000 students in basic sciences. Some will become pharmacists, nurses.
This is massification.
And it hasn't happened yet. We're still producing we have 11 medical schools or 12. We produce about maybe 500, 600 a year. And it's not enough. So tell me, like, I've never heard of massification, but it excites me.
No, massification, you have to pass an exam for 500 students. To 1,000 students. Paper examination is huge to manage, huge to correct.
So this is like, it's just like even common sense. It's not like digital assessment is a matter of course if you're going to do large massification.
So, yes, so now in our faculty, every student has a tablet. When we have controls or exams, we call them, they come here in the amphitheater, and we have the exam on their tablets. They have 1 hour to respond. The exam is finished. We have the results for everyone.
By the time the exam is finished?
By the time the exam is finished, we have the result for each one. And we have also the statistics of the exam. If there is a problem with the question, if there is a problem of learning, of teaching, and we can correct everything. And the student is not the victim of the exam. And other thing is equity. The students will be equal. There is no fraud. Though digital examination bring this, so our university, it was easy. It was a success to do digital exams. So we moved to other aspects. Clinical exams.
Clinical exams?
Clinical exams. So for final clinical exam, we do OSCEs, which are objective structured clinical examination. Before, when we were doctor, the final clinical exam, we came to a jury, 3 persons. They send us, we examine a patient, and after we come, we read an observation, and it depends if he likes you, if he doesn't like you.
Or if he's in a bad mood. Or
in bad mood, he can ask a question, you can't respond. So, a lot of subjectivity, subjective exams. Now with OSCEs, the students, they come and they pass 6 stations to 8 stations with different evaluators, with the simulation stations, and he's evaluated about the whole competencies a doctor will have. And we added a platform with digital, so examiners don't intervene, just they check, done.
Wow.
After the exam, we have the result. We have, if a station is not adequate, we can leave it from the evaluation, and the digital bring us this aspect.
This aspect.
Yeah.
Wow.
Also, massification in the workplace, in internship. So the students, they have a platform. When they arrive, they affected to services. So when they arrive at the service, they have the objectives for this service.
If it's obstetrics or pediatrics or whatever.
So when he's in the service, he opened, he has the objectives, he has to learn, and he has to have competencies, he has the need to develop in the service. And after, the professors have also the same platform. When the internship is finished, the professor or the instructor come, check, you have the note and the score.
Wow.
And we are developing also a portfolio. Portfolio is my own portfolio, my own carnet, where I document where I live in the hospital, where I live when I assist, when go to a congress, and I do every day a reflexive discussion about what I'm thinking, my critical thinking, what I'm improving, I'm in my learning, etc. And in these e-portfolios, we can add a system that you can be mentored with a tutor. So it's a tool also very important for learning and for assessment.
For assessment.
We can assess the trajectory of competency of our students. So now we started a pilot process with e-portfolio in medical specialties, and next year we will launch it for all our medical students.
Wow.
So with these digital aspects, we have other digital aspects. We have knowledge, we have clinical, we have simulation. Simulation also, we have virtual patient, we have activities that done in simulation. They are data. We can collect them, and my hope, my project is in the future we can, for every student, we can see his progression through the data we collect from knowledge, from clinics, from internship, from e-portfolio, and we see at each time if he has difficulties in knowledge, we can help him to gain knowledge. If he has difficulties in some competencies, we can remediate about this. So we can understand the progressive evolution of competencies.
Wow.
Excuse me. And finally, the discussion about the duration of medical studies, it will not have any sense, because some are brilliant. They will gain competencies in different aspects in a short time. I can give him his diploma and his certification.
So you mean medical school can be 2 years or 3?
No, not 2 years. No, it's impossible.
I know, I'm exaggerating.
In terms of difference in 6 months, or
6 months.
But in continuous education or in some certifications, it will be marvelous.
Wow, this is almost too good to be true. So I'm blown away by the whole thing. And this was all something that you had to oversee because you're the one in charge of AI and...
Yes, because now I'm not talking about dreams.
This is a reality.
Exists. And now with artificial intelligence, the analytics, the learning, it will be very easy and faster and artificial intelligence, I didn't talk about that. Since the first month of my, when I moved to Casablanca, I arrived in the amphitheater and I saw all students, they have their phones and tablets opened during the course.
During the course?
During the course. And I approached, and I found that they're using immediate transcription through AI. And in these platforms, they can do after the course, they have the transcription, they have the mind mapping, they have generator of MCQs, they have an abstract of the course. So I said they are using things by themselves.
And what year was this? Which year was this? 2014?
2023.
23?
Yes, 23. And I saw that very interesting. They are much more advanced in using tools than us, and professors don't know about it. And they are using some materials that may cause errors for them and with consequences to their learning and assessment. So we discussed with the pedagogic committee to do a platform, first to start modules for teaching AI to students.
In the medical school, as part of their curriculum.
Teaching AI to professors, and to create a platform with double access, one access for students, and we give them AI tools, some done by our engineers, Revis AI for example, so they can put their courses and they help them with revising, with MCQ, but validated by our pedagogical committee and by our teachers. So we give them all the tools that are adaptable to their learning and progression, but we validate it. And also we teach them how to use these tools, AI tools, with responsibility and ethics.
Ethics.
And
so they are not cheating,
yes,
doing...
sure.
Okay.
And also there is a platform for professors that help them using AI tools for courses, for making interactivity, for making quizzes during courses, for doing flipped classrooms, and also for building MCQs and examination and things like this. So I'm very happy with this, and we are tracking how they use, how the results in exams are evolving, improving, depending on their using of the AI tools. So we are publishing some articles about this aspect, and for sure AI will be our biggest tool for what I said before. With this 360 digital system, we will with AI we will have a tracking of a competence map of each student.
In your process of massification.
In the process of massification.
Wow.
For sure.
So what did you learn all this digitalization from maybe UK or Europe, or was this all engineered from within Morocco? Like implementing the 360?
Implementing, for example, the learning management system in our university is I can say the name. It's international learning management system. It's bought by the university. It's Canvas, which learning management contains also video streaming, quizzes, and AI.
Yeah.
For knowledge assessment, we have a platform, a French platform, Evalbox.
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 Yes, a French platform, very good one. But that's what I found. But after, because as I told you, we in the same commissions we have engineers, we have professional engineering in dentistry, and we try to benefit from collective intelligence, our collective intelligence, interprofessional collaboration. So I asked some developers and engineers from our system, and all what I talked about, my Ecos, eStage, ePortfolio, all these platforms, IntelliGES, UMCSS, all these platforms are done by our developers and engineers.
Wow.
100% made, local made.
So where is your school going to be 5 years from now? I mean, like, if you're doing this at this time, what do you project in the next 5 years?
First, I think we will go to other cities.
More medical
cities, yes.
So you have 6 medical schools now. You're going to do more massification.
Because now we are in the biggest cities, but one of our concerns, and His Majesty, the King of Morocco, in months ago, said we don't need a Morocco with two vitesse.
Life is Vita life?
No.
Say it in French, maybe.
Vitesse. With two parallel difference, because we have rural regions, rich regions. We want that
unified. Everybody should have the same access, equity, quality.
Every region, every economic and social background need to have accessibility to doctors, to nurses. We have a big lack in workforce.
So let me explain it.
In Africa.
If I don't say it, what you're saying, he doesn't want a situation where the rich and mighty have all this good healthcare system, and then those who are in the rural areas, different vita, not good, poor access.
Yes.
He wants to bring it all together.
Yes, development have to be equity. I supervised research years ago about what is the output of the doctors certificated from our faculty, and I did it nationally. So we found that if a student from region went to the big city.
From the rural area, you
From
mean?
rural area to big city, doing medical studies, 85% of them stay in the city and
They
don't
don't
come
go
back to the region. Because it's long studies.
It's similar in
we
the
marry
US.
with it's developed.
Oh, you said they'll marry, they'll see
Yes,
it's the same in the US, in Ghana, everywhere. You
Everywhere.
pick them from the rural.
So the solution is multiplying medical schools near to the
in
population.
the people. Oh.
So when they finish, they stay and they serve their population. And that's what is social assumption involving all the components. So if it evolves socially, this region, there will be cafes, there will be hospitals, there will be schools, there will be economic improvement. So that's one of the objectives of our university and our foundation is to reach more regions and to make Moroccan citizens with equitable access to health and to education.
This is genius because, you know, Minneapolis, United States, a lot of rural, they had to do this to keep doctors in, and we may have to do the same in Ghana and all these other. So everything you're doing, is it from the King of Morocco? Is he the one?
His vision. His personal vision.
So you are executing his vision?
Yes, his personal vision. He's the president of our university.
Wow. So that's what every leader should. You know, a lot of leaders are disengaged. They don't really care what's going on, and they're talking about money, finance, oil. They're not focused on the health. Yes. But your king, what's his name?
Mohammed VI.
King Mohammed VI of Morocco.
Yes.
It's his vision.
And another vision because...
Oh God, I wish every African leader would listen to this.
In public system, there is bureaucracy, there is difficulties of financement. With this creation of our university, which non-profit partners to the state, to the public system, we have also the agility to create things like these platforms, like to have the agility to create locomotives and experience and innovation. And if it works in our system, we give to the Ministry of Health or to the Ministry of Higher Education. That works with us. And for example, EvalBox will be generalized this year for all the public universities.
Is the evaluation, the one that the
platform for evaluation on tablets.
They document everything, and then it will be generalized to all the
universities in Morocco, even non-healthcare.
I am shocked. I am. How many doctors?
That's your vision.
So it's all about leadership. How many doctors do you have in Morocco? Or what's the population of Morocco and how many doctors?
We are about 38 million.
38 million.
We have about 32,000 doctors. And the lack is 28 or 30,000 needs of doctors in Morocco.
Okay, so I'm going to repeat.
We are less than the optimal.
Okay, I'm going to repeat that number in regards to my country. You are 38 million. We're about 36 million. We only have 10,000 doctors. You have 36,000 doctors. And you're embarking on massification. Ghana is not doing any massification. We still have 11 medical schools and crawling. And you are already doing massification. How many doctors are you now producing a year? Because
this year, with the entrance in the non-profit, the public, and the private universities, we have also private universities. It's about 5,000 students will start in first medical year this year.
So your country, which has 38,000 doctors, is looking at producing 5,000 every year.
That's the objective, vision. But we have problems because students need internship. We had discussion with students, with professors, because if you give this massification, you need to have much more professors. You have to do tools for accompanying this massification, and digital tools are very important.
So is that the main challenge you've had with the massification, the professors? Because the digital part, you've taken care of it. It's just getting more professors. So how are you solving that? How are you getting more professors to?
We are recruiting professors
From across the continent?
Across the also we have in my university at least we have 10 professors from Mali, from Senegal, from Côte d'Ivoire. We have professors from everywhere,
Okay.
but we are investing on your people first, and when we recruit professors, we invest in teaching them pedagogy, train the trainers.
So you're training, like you guys are acting smart. You're training the lecturers, you're investing in digital. So you are far advanced of a lot of African countries, because Ghana doesn't have what you have. So what can we do? I mean, how can you partner with others, collaboration? Like I am doing this thing about connecting medical students and doctors, Akoma Health Sciences Society. How can we partner with you?
That's another vision for His Majesty. The King says all the time that we have to find solution by ourselves.
By ourselves,
we have
as
to
Africans.
believe in ourselves.
Have faith.
We have to believe in ourselves. COVID taught us that we can be, we can do, we are capable of many things, but we can't do it isolated.
We've got to work together.
We've got to work together for that and build things. So my presence here in the Consortium of Africa.
So the King's vision.
So is to build together. For example, in university, we created in Dakhla the African Academy of Health Sciences. And this consortium of COMSA is very important opportunity to exchange, to collaborate, and to open barriers. And we can make bridges with our students and our teachers. It's very important for us to improve together.
Wonderful. So are you able to invite me to meet with your students and maybe even meet your king and your faculty and students? And I'd like to collaborate
we say marhaba.
Marhaba. What does that mean?
Welcome.
Welcome. Okay. So what do you have to say? I mean, we've talked a lot. What do you have to say to the other deans who don't have this digital assessment, or maybe not even able to afford it, or even to presidents, like your king is in charge. Yes. What do you have to say to the other African presidents to get them to take charge?
Political, I don't like politics, but it's always about, we have to believe in ourselves. We are capable, even with low costs. The most important thing is to exchange, to train. pedagogy, and to build progressively.
Okay.
And if we do it with Nia,
with a good heart.
With a good heart.
Is that Niha? Is that what it means?
Yes, good heart.
Good heart. With good Akoma.
Exactly.
This is called Akoma Conversations with the good Akoma.
There is a quote, Ubuntu.
Ubuntu.
I am because
you are.
Exactly.
So I also teach you a Ghanaian word, Akoma for heart, and this is Akoma Conversations, talking from the heart. Okay. So it's been. I think they need to get going, but it's been delightful talking with you. I think we'll talk more outside of this because I see a lot of opportunity to learn. Leaders need to come and learn from your president, and our medical schools will have to come and learn from you as well. Sure. I'm really excited. I've learned a word, massification. I've always thought of it, but I feel like, am I being too much? But you have given me an example that you can have 5,000 output. So thank you so much.
Thank you.